Hey everybody, we're going to get started in maybe 2 or 3 minutes here. Just let some people join in. All right, everybody, we'll go and get started now. As usual, thank you so much, everybody, for tuning in. We've had some amazing support from you guys. We really appreciate it. We're excited to be able to offer you guys these opportunities. We're working with a lot of really cool PAs right now. And like we said in the last video, November should be a really good month for us. So you'll be able to get all of that great experience and see like diversity from a lot of different specialties. We try and do a different specialty every time, different parts of the US, and most importantly, those shadowing certificates. Just kidding, but that too. But on that note, I'll go ahead and let Alia talk to you about the shadowing to certificates and how it's going to work today.
So as always, there will be a quiz at the end of the session. We'll link it in the chat at the end whenever she's finished speaking, and then I'll put it in the link on our Instagram as well. And then you do have to get at least 4 out of 5 correct to get the certificate.
Awesome. So if you guys have questions any point throughout the presentation, go ahead and ask them. We want you to be as active in the chat as you like to be. We love to see it. I'll be taking down all of the questions. So if it does get missed somewhere throughout there, then I'll try and ask it at the end so that you know, it just doesn't go unnoticed. But yeah, that being said, guys, we're going to go ahead and get started. Vivo, are you ready on that side?
Yep, I am.
Okay, perfect. It's all you. Take it away.
Okay. see, share my screen. Okay, hi everyone. Oh my gosh, I am on the YouTube live comments and I see so many people from all over the country. California, Virginia, there's someone from Sri Lanka. So that's just so amazing to have everyone here to join me today. I know it's such a hard time for everyone to gain clinical hours and shadowing hours, so it's my greatest honor to be here. So let me just start this. Okay. Sorry if it's my first time doing this. So if there's any technical difficulties, please bear with me. If you have any questions regarding about anything I talk about regarding myself, my experience, I do have a Q&A portion at the end, so you can ask me those questions then. However, as I'm going along with the case, if you do have a question regarding a particular case, then you can ask me in the chat box, and then I'll try my best to answer them. Okay. All right, so hi everyone, my name is Vivo. I am an urgent care physician assistant, and you may know me as Vivo PA, Vivo_PA from Instagram. If you don't follow me already, please follow me. I have some great contents on there, and I'm excited to be posting more in the future, some funny videos, entertainment, as well as some educational content as well, okay? Okay, so a little bit about my background. I was actually born in Vietnam. Any Vietnamese or anyone who was born in another country out there, let me know in the comment below. I was born in Vietnam. I immigrated to the US when I was 9 years old. I lived in California, Anaheim, California, for a few years. Then my family and I decided to move to Florida, and we lived there for over 10 years. So I went to school there, middle school, high school, college, and PA school there. Currently, I'm living in Arizona, and I've been living here for the past 2 years now. And I went to college at the University of Central Florida. I got my Bachelor's of Science there. I started in May 2012 and finished December 2015. My major was Health Sciences Preclinical. And then I went on to PA school at Nova Southeastern University. I started in May 2016 and finished August 2018. And so for college, I actually finished a semester early. The reason why I did that was because when I was researching all the PA programs, oh, I love seeing all the Vietnamese representations. Thank you so much. When I was researching the PA programs, a lot of them started in May. And so I knew that if I did the 4 years of college, I would have finished mid-May 2016, and I would only have 2 weeks until I start PA school. And you may or may not know, PA school, we don't have long breaks. We don't have summer breaks compared to like medical school. They have summer breaks, but we don't. We have to continue on doing like a semester after semester. So knowing that, I didn't want to go straight into PA school after college. And so I combined a lot of my classes and made my schedule so that I can finish a semester early. That way I can have a semester to travel and to work, get some extra money, prepare for PA school, and it worked out. And so PA school is usually 2 years, May to August 2018. I graduated in August. I studied for 2 months for my boards, and then I was certified in October. Okay, so one of the most commonly asked questions that I get from pre-PA students is, how did I get my healthcare hours or patient care hours? My recommendation is to start early. I recommend, if you know that you want to be a PA, which I'm sure all of you guys who are here today are interested in becoming a PA. That's why you're here, right? And so start early. If you know that you want to become a PA, I started after high school. And so my first year of college, I was able to look into how to gain clinical hours right away. I looked into, CNA, phlebotomy, medical assistant, paramedics, EMTs, but I felt like CNA had the least amount of training. I took a class for like 4 weeks, so a month, in order to get my license so that I can start working. I didn't want to spend too long to get my license because I wanted to start right away, because I knew that PA schools really needed you to have a lot of hours. So I got my CNA license during my first year of college. At the time, I did apply to a few places, but a lot of them didn't meet my schedule, because keep this in mind, I was going to school at the same time. So it was very hard to navigate, working as a CNA and also at the same time attend these college courses. And so I couldn't find a job that fit my schedule. Something came up that was recommended to me by one of my friends, was an organization called Shepherd's Hope. It's a nonprofit organization that helps uninsured patients get care. And that stood out to me so much, because I'm going to talk about it later, but what my mission in life and why I wanted to go into medicine was because I wanted to help the underserved, and I wanted to work with patients who didn't have insurance and who could not afford it. And so when I heard about the organization, I was so excited that it fits with my mission in life. And at the same time, I can volunteer and help them out as a certified nursing assistant. And so I started doing that first year of college, and I continued to do that until I got into PA school. So I did that for 3 years, only volunteer like once a week, for a few hours a day. If you are in the Orlando area and you're working, you go to UCF or in the Orlando area, definitely reach out to them, because that's where they're located. Volunteer there. It's such a great experience, and I talk about them so much until this day. Great organization. Second year of college, I decided to look for more jobs. I found an organization, a company that works with kids with autism. And I really like that, because I've always wanted to work with kids with autism, to learn more about autism in general. And so I applied for this company, and they hired me as a CNA, but they also trained me as a home health aide. It was a small course, certification, class, a course that I have to take in order to be qualified as a home health aide, just like a small training course, basically. And what you do is you go to their house and you help the parents out. You help change the kids, feed them, bathe, groom, play with them. And it was a great experience. But as I was progressing into my college careers, my third year, it got really busy with the amount of courses, and the courses were harder too, that I didn't have time to work as a home health aide anymore. So I did that for a year. And then I had to stop because of my school schedule. But I continued to volunteer at Shepherd's Hope. And that was the majority of my hours, where the patient care hours came from, was from my volunteering. I also did like a small volunteer here and there, like as a front desk person at a dermatology office. I did include that in my application as well, but it wasn't a lot of hours. And then lastly, I did work as an optometry technician during my college years. I know it's very random. Like, why would I work as an optometry technician, right? Without going to optometry school. This came towards the end of my college career. It was like towards the end of the third year, where my friend recommended to me, hey, like, look into this. It's close by where you live. Maybe you can gain some extra hours from doing this. And so I just applied, and I got in, and they trained me, and I worked for them for like half a year. So that helped with the number of hours that was required as well. So when I applied for PA school, the number of hours that I put down was like over 2,000 hours. I know some schools, the one that I applied to, the one that I went to, NSU, Nova Southeastern, only require 500 hours, but I wanted to be able to apply to a lot of programs. And so one of the programs, UF, required 2,000 hours. And so that's why I worked so hard in order to gain a lot of hours. Okay, next. So urgent care physician assistant, why medicine, why PA, and why urgent care? So I'll talk about why medicine in the first. I'm sorry, I'm getting distracted by the comments. So I'll answer the questions later after I finish talking about these topics. But why medicine? I did brush on that a little bit earlier. When I first immigrated here, my mom was diagnosed with thyroid disease. At the time, she has such a big goiter. A goiter is like basically a tumor and a mass from the thyroid disease on her neck that she needed to get surgery to get it removed. With that being said, she also needed long-term treatment as well. And at the time, being like an immigrant, we didn't have that much money. We used a lot of our money towards buying a plane ticket, getting a place to live, in other areas that we needed to spend money on. We didn't have enough money to get her the surgery and the long-term care and treatment. And so we struggled a lot to get her the health care that was needed. What helped us was we rely on like the nonprofit organizations, the local communities to come together to help provide healthcare for my parents. And that was the initial spark in my interest for medicine. I wanted to go into medicine because I wanted to be able to provide care for patients who cannot afford it, to serve the underserved, and to work with patients who need healthcare but cannot afford it. To me, I feel like healthcare is such a basic human rights that it's crazy how if someone doesn't have money, they can't get the proper healthcare. And so that's why I made that my mission, to go into medicine for that reason. But why PA? Why not, excuse me, why not physician or NP? So that's another question that I get a lot from pre-PA students, like why PA? The biggest reason is flexibility. When I first heard about the profession, it just blew my mind that you can work in one specialty and a few years later just jumped into a completely different specialty. You can do family medicine for 4 to 5 years and then decide to go into something completely different like surgery, and still be able to practice without having to go back to school, without having to do a residency. Physicians can't do that because once they choose a residency program, a specialty, they can't go back they can go back, but they can't just jump to a different specialty. They would have to go back and reapply for that residency program, go through the training, whether it be 3 or 4 years, and then possibly do a fellowship for that one particular specialty that they want. For us, we don't have to do that. We can just apply to whatever specialty we want. And as long as we get accepted and they're willing to train us to work in that specialty, we can do that. So that was what pulled me into that direction. Another reason is the collaboration between the different professions. For me, like I really like how I have a lot of autonomy. Being at the urgent care, I'm allowed to, I'm the only provider there. I call a lot of the shots. I make a lot of the decisions in the patient care and plan. But at the same time, I do have my supervising physician, not on site, but available, so that whenever I face a certain case that I'm not sure about, I can always contact them or reach out to them. Being a PA, you will never feel alone. You will always have a team with you. You will always have your attending physician or supervising physician being available, so that whenever you're not sure about something, you can always go to him or her to get advice. So that's what I really liked, right? Especially being a new PA, it's going to be really scary. And knowing that someone has your back is just, it's just great. Another reason is work-life balance. I did shadow a few physicians, and I feel like majority of them didn't have enough time to allocate it towards other areas. For PAs, we work maybe 40, 50 hours on average a week, but I know a lot of physicians work way more, maybe 60 to 80. And so a lot of them are very busy. So they're not able to allocate their time towards other areas of their life. And for me, I wanted to later on have my own nonprofit organization. I want to try doing like other things that I'm passionate about. For example, I really like competing in pageants. So being a PA allows me to do that. Working at the same time, pursue other passions in life. And also, last but not least, less schooling means less debt, right? Coming from an immigrant family, like we struggle a lot financially, and I didn't want to be in such a large debt and put my parents through that because I have to pay everything for myself. And so I know a lot of my friends who are physicians who ended up with $200,000 to $300,000 in debt after medical school versus PAs versus, well, I can't speak for other PAs. It just really depends on circumstances, but generally it's less. For me, I ended up less than $100,000 in debt, a lot lower compared to those who are in medical school. Why urgent care? Why not another specialty? I was deciding between dermatology or family medicine or internal medicine or even emergency medicine after PA school. I was offered a job in a dermatology office after I finished PA school, but after thinking about it for so long, I decided to go into urgent care because I felt like after you finish PA school, it's good to be exposed to as many diagnoses and medical conditions as possible, because then it can solidify what you have learned in PA school. I feel like once you jump into a specialty after PA school, you might be rusty in other areas. So I think it's good to do like family medicine, internal medicine, or even urgent care for a few years and then jump into a specialty. I think that's a great way for you to not only solidify what you learn, but at the same time, just move forward and specialize what you go into the specialty that you like. Okay, so what is my day like? I see a lot of questions here, but I will answer them towards the end where the Q&A is, but keep putting your questions in the comments, please, and then I will answer them towards the end. So what is my day like? Generally for urgent care PAs, we are like ER providers. We only work like half a month. When I first started, it was around 12 shifts. That's the minimum. That's the requirement of how many shifts you're supposed to work per month. So 12 shifts is the minimum. But you can go up to anywhere to like 15 or 16 shifts per month. Right now, after working in the urgent care for 2 years, I usually work anywhere from 15 to 16 shifts. But in the months where I'm busy, I will just pick up 12 shifts. So that's the beauty of it. It's very flexible. Compensation, how do you get paid? So we get paid hourly. So let's say that you work 12 shifts a month and you want to pick up extra shifts. You want to work 14 shifts or 15 shifts or even 16 shifts. You get paid for the amount of hours that you work. And so that's what's great about it. The more you work, the more you get paid. So that's a great incentive to pick up more shifts, right? We usually start at 7 a.m. and ends at 7 p.m. So our work days are 12 hours a day. Sometimes patients will come in really late. A different clinic is different. Sometimes other clinics will stop taking patients like 15 minutes prior to them closing. For our clinic in particular, they're very strict about when we can stop taking patients. My manager only wants us to stop at 7 p.m. on the dot. So let's say a patient comes in at 6:59, you still have to take them. And sometimes they can be complicated. And so that requires you to stay after for maybe like an hour or sometimes an hour and a half if it's a procedure that you have to do. So sometimes I'll go home at like 8:30. But that's the latest that I have stayed. I don't think I've stayed until like 9 o'clock or anything. But the beauty of it is that if I stay late, I can charge them for that because we get paid by hourly. So let's say I worked 14 hours that day, I get paid for those 14 hours. So that's a great motivation incentive for you to, so that, you know, you're not like, oh my gosh, I'm staying late. Like I'm coming home really late. What is my day like? Usually we open at 7 a.m., but then if the patient shows up at 7 a.m., they still have to fill out the paperwork and they still have to get checked in. So you have that 15 to 20 minutes window in the morning to get other things done, other tasks done. So usually how I spend it is by answering my emails. My medical assistants on my day off will send me emails about a particular patient, or even my coworker will email me about a particular patient. Hey, this patient came back. This is what's going on. I just want to give you an update. What do you think we should do moving forward? Blah, blah, blah. So I'll answer those emails. And then I'll also go over labs. That's very important. At the urgent care, we don't have a lab. My urgent care, we don't have a lab in the house. So we have to send our labs out to either Sonora Quest, LabCorp, those big lab corporations. And so once we get the results back, it's our job to go over the labs and explain the results and send a message to our medical assistant. Right now, we have a lot of COVID labs because we've been doing a lot of COVID testing. And so what I would send to my medical assistant, something like, please inquire, excuse me, please inquire how patient is doing and inform he or she that their COVID test is positive or is negative. Right? And then you give them instructions like, please follow up with their PCP within 24 hours, make sure to follow social distancing guidelines, and then you give them ER precautions, and then you send it to your medical assistant. And then your medical assistant will call the patient and then will relay the results. And then after they contact the patient, the medical assistant will send you a message and say, oh, the patient was contacted, she feels great, or, oh, she still has shortness of breath and she's still coughing a lot. The medications are not working. And then those messages, I will call the patient back directly myself to talk to them, and I will ask them more about their symptoms. And if it's something that I can't really give advised over the phone, I will tell them to come back for a follow-up. Usually though, I will tell them to come back so that I can reevaluate them if they're still having symptoms. I chart as I go. So whenever I see the patient, I'll try my best to chart. Sometimes if we see like 40, 50 patients, it's hard because you have to spend really maybe like 10 minutes with each patient, or even sometimes 5. So it's really hard. If on a busy day, you just try your best to chart as best as you can, but sometimes I'm not done with them by the end of the day. I will work on them the next day if I'm off, or the next off day. And you get paid for that. You get paid for charting, which is great, because if you bring it home, you work, let's say you spend 2 hours charting, you get paid for those 2 hours. I know a lot of my colleagues who are also at the urgent care, they don't get paid for charting extra times. So if they go home and they're not done with their notes, they have to chart at home. And sometimes you can spend a good 4 to 5 hours charting, depending on how complicated the cases are. And they don't get paid for those 4 to 5 hours. So it really depends on what urgent care you work for, or what company you work for. Some fun facts before we move forward with the cases about myself. I was born a dirty blonde. So if you see a picture on the left side, that's my dirty blonde hair. But I just grew up, and I guess I just turned Asian. Because I looked mixed there, but I just turned Asian because this is my natural hair color. So it just turned brown for some reason, but I was born dirty blonde. I can lick my elbow. I'm not going to demonstrate that. Maybe in the future, if you follow my Instagram, I will, maybe I'll do that. I'm currently the 2020 Miss Asian America. I did the pageant virtually, actually. Usually it's in person. in San Francisco, but this year, due to the pandemic, we had to do it virtually. So I just got crowned a couple months ago, back in August. Some hobbies of mine: I like to sing karaoke. Not saying that I'm good at it, but I like to sing all the time in the shower, sometimes at work. I like to hike. Being in Arizona, there's a lot of good hiking places. If you're ever in Arizona, let me know. So I'll give you some good recommendation on some hiking places that are very, very beautiful. Another hobby of mine is I like to watch TV shows. That's how I de-stress, right? A lot of shows. Okay. So some disclosure, just all opinions are my own and no way represent the practice that I work for or all the urgent care PAs. It's just my own judgment and my own opinions. Okay, first case. CC is chief complaint. So it's whatever the patient comes in for. So whatever they're concerned about. In this case, chief complaint, flu-like symptoms. Right now at my urgent care, we are both doing telemedicine visit as well as we're seeing patients in their car. If they're having symptoms that could be COVID, we like to separate them from patients who are being there for regular complaints. So if they're coming in for anything like flu-like symptoms or anything upper respiratory, we do ask that they stay in their car. And then we'll dress in PPE and go out to their car and examine them, because there are patients who are being seen inside the clinic for STDs, UTIs, sports physical, things that are not COVID related. So you don't want to put them together. You don't want to bring the patients with COVID symptoms inside the clinic, because that can expose the other patients. So HPI. I'm going to read it out first, and then I'll go back and explain what the words mean, because I know some of these are like medical terms. So 64-year-old male presents to clinic, complaint of body aches, chills, subjective fever, sweats, cough, nasal congestion, rhinorrhea, sore throat for the past 2 days. Patient reports yellow-green sputum with coughing. He also reports shortness of breath, only with cough spasm. Denies hemoptysis, wheezing, chest pain. Patient also complains of intermittent abdominal pain that started today. Describes it as a dull pain located at the umbilical region, non-radiating. Reports 1 episode of diarrhea without mucus or blood. Patient also reports on and off nausea, but still able to tolerate solids and liquids. Denies vomiting. Denies any recent antibiotics, new or different medications or foods, sick contacts, recent travel, denies any past GI issues. He had a cholecystectomy more than 5 years ago without any complications, no other surgical history. Reports running errands, but no confirmed COVID exposure. So I'll go back and tell you why I asked certain questions or what each word kind of means, because I know I want to say in layman's terms so that everyone can understand. For the first sentence, why subjective fever? Why not just say fever, right? So, but when you work in medicine, you will come in contact with a lot of patients who might think 99.8 is considered a fever. And so if they come in and they say, hey, I had a fever, it's good to ask them do you feel feverish, or did you measure your temperature? And if they did measure their temperature, it's good to ask, what was the temperature? In this case, this gentleman did not measure his temperature. He just said, oh, I felt feverish, but I didn't really measure it with the thermometer. And so that's why you say subjective, because it's not really considered a real fever. 100.4 is considered a low-grade fever. So anything below that, maybe like around 100, I would consider like a low-grade fever too. But 99.8, 99.9, I really don't consider that as a fever. Rhinorrhea is just a fancy word for runny nose. The reason why I asked what color their sputum is because usually when you're coughing, you can either have a dry cough or a productive cough. When you're having a productive cough, you're coughing up phlegm. It's good to ask what color it is, because that can help you determine or come up with a list of differential diagnosis, or what kind of, if they have pneumonia, what kind of bacterial infections. The color of the phlegm can give you hints in regards to that. So this gentleman, his phlegm is just the normal color, yellow-green color. And then he also had shortness of breath with cough spasm. It's important to ask them, are you short of breath only like with exertion? Are you short of breath when you're coughing? Are you currently short of breath? Are you just constantly short of breath? For him, he said that he is only short of breath when he's having that cough spasm. So that's good to know. Denies hemoptysis. Hemoptysis is coughing up blood and wheezing. Chest pain. CP is chest pain. He also had GI issues, GI complaints. So that's odd, right? Usually patients come in with just upper respiratory complaints. This gentleman, though, had that, and also at the same time, GI complaints. Abdominal pain that started the same day today, or the same day the case was. It's good to ask what kind of pain it is. Is it a sharp? Is it a dull pain? So that you get a better idea. This guy had a dull pain. Location is very important for abdominal pain. Keep that in mind. Umbilical, it can suggest like gastroenteritis, like a stomach flu, for example. If they have right lower quadrant pain, it's, does anyone know what that would suggest? I know there's a lag. But if you don't know, I can just tell you. Good. Appendicitis. Good. Wow, you guys are so smart. Very good, very good. Yeah, I'm seeing a lot of comments for appendicitis. Oh my gosh. Someone mentioned hernia. Yeah, possibly. Could be a hernia too, but usually appendicitis for the right lower quadrant pain. If they had like left lower quadrant pain, maybe like diverticulitis. If they have epigastric pain, that's the area where, I'll show you like right here. So that would suggest maybe like a peptic ulcer. Sometimes like if they have like H. pylori, it can have, because of the peptic ulcer disease, they can have pain there as well, epigastric. So it's good. It's very important to ask the location of the pain. And then also, does it radiate anywhere? Does it go anywhere else? He also reported 1 episode of diarrhea. The reason why I ask if there's any mucus or blood in it is because usually if there's blood in that diarrhea, you might have to think about like bacterial infections, for instance, right? And so, and also it's very important to ask how many episodes of diarrhea are you having a day? If they're having, let's say 2 episodes today versus 20 episodes, that's such a huge difference. If they're having 20 episodes of diarrhea, they should be seen in the emergency room because they're most likely are dehydrated at this point. Versus 2 episodes, oh, not that significant compared to 20. So ask them how many times are they having the diarrhea, and if there's any blood or mucus in it. He also had nausea that was on and off. But with nausea, it's good to ask if they're still able to take medication orally, tolerate solids and liquids. This is important because later on when you prescribe medicine, if you're giving them tablets and pills, they have to take it orally. If they can't tolerate that and they're vomiting the medication up, then you can't really, it's pointless to give them oral medications at that point, right? They might need IV medications if they're not able to tolerate PO, which is oral. And then also antibiotics. Good to ask about if they're taking antibiotics at this point because they're notoriously known to cause GI upset, especially diarrhea. So let's say that he started a Z-Pak yesterday and he's having diarrhea. Well, that's most likely your answer, right? Something to think about. That's probably one of the side effects. So that's why you're having the diarrhea. So it's good to ask if there's any medications, if there's any antibiotics that they started recently. Another thing to ask is foods. Did you eat anything weird that you could think of yesterday? Maybe the guy came in and was like, hey, I had some old chicken yesterday. There you go. You have your answer. So it's good to ask that. Recent travel history is very important. Did they go to another country recently? Maybe that can give you a better idea of your final diagnosis, depending on their travel history. Any past GI issues, like past conditions. You can have IBS or IBD, irritable bowel disease, or irritable bowel syndrome, or inflammatory bowel disease. Like if they had a history of Crohn's or ulcerative colitis, that could cause them to have GI upset and diarrhea. So those things are good to know and mention in your main HPI. Any surgical history, do they still have their appendix? Because if they had it removed like 5 years ago, you can rule that out of your, when you have your diagnosis, differential diagnosis, you can cross that off the list, right? If they already had their appendix removed. And then the reason why I asked any COVID exposure, usually before the pandemic, I mean, you don't really ask about that, but it's very important now to ask if they had come into contact with anyone with COVID recently. If they said, hey, I'm living at home and my mom is actually positive for COVID, that should be on your list of differential diagnosis, if that's the case. Okay, so next, allergies, past medical history. So this guy had no allergies. He's not taking any medications. So the second one is PMH, past medical history. Medications, none. Surgical history, like we talked about. He had a cholecystectomy over 5 years ago. Yes, so someone asked, what does non-radiating mean? So radiating means, basically, it moves to other area. Non-radiating means that it's localized. It stays in the same area. That's good to know, because if the pain is going to other areas, then you might have to think about other kind of diagnosis as well. But it looks like someone already answered them, so thank you. Okay, so social history. Yeah, for these cases, please ask me the question as we go so that I can answer them, because it would be really confusing to have to go back to answer them later on. Social history, he doesn't smoke, doesn't drink, he doesn't use any drugs. So this guy is just a generally healthy guy. Only had a surgery. Okay, next part, vitals. Can anyone tell me if these vitals look normal? Let me know what you think. Okay, good. So someone said tachycardia. So tachycardia is basically fast heart rate. I got high blood pressure. Yes, blood pressure is elevated compared to the usual normal blood pressure. Below 120/80 in textbook, right, is normal. But in this case, usually in person or in clinic, 127/85 is not significant at all, even though it's elevated, consider elevated in textbook, it's not significant. Low grade fever, very good. Perfect. Yes, he does have a low grade fever. Someone asked, where is the umbilical region? I'm sorry, I should have said that. Umbilical is where your belly button is. And so he had pain in his belly button, around the belly button region. Okay, let's see, pulse elevated. Yes, pulse is a little elevated. It's on a higher side. Very good. Yes, so I'm seeing a lot of low-grade fever and tachycardia. Those, yes, that's perfect. That's the two things that I wanted you guys to know. Everything else is pretty within normal limits. Okay, good. You guys are so smart. I'm very impressed. Yeah, someone did mention O2 is a little low, but not concerning, borderline. 95, below 95 I would consider a little concerning, but yes, it's borderline. 95 is not bad at all. If they're at 93, 94, I would have the medical assistant remeasure their oxygen because that would be considered a little low for me. But 95 and above is good. But yes, someone did mention that it's borderline. Very good. Okay, physical examination. So this guy, you look at him, he's just well-developed. So WDWN is well-developed, well-nourished. So alert, he's not in any distress whatsoever. He's sitting there comfortably. It's very important, right? If he's having abdominal pain and he's like scrunched up and he's like holding his belly, that can tell you how much pain he is in. If he's just sitting there comfortably, then the abdominal pain is not that great. Skin, warm, dry, no rashes. That's great. So everything looks clear. You guys can read this. Everything looks great. If there's anything that I need to explain, then something that you don't understand, then let me know. But everything looks good. Let's go down to cardiovascular. So he is tachy. So usually RRR is regular rate and rhythm. So for him, he's tachy, but his rhythm is normal. So he's constantly like tachy. No murmurs, lungs are clear. That's important because he's coughing. So you want to hear his lungs. You want to auscultate. Auscultate is listening to their lungs. You want to see if it's clear or do you hear any coarse, any funky sounds in there in the lungs, any wheezing. That's important as well. So this guy, breath sounds are equal, no wheezing, lungs are completely clear. Abdominal exam, very important. You listen to their abdomen. You want to see if it's like hyperactive meaning it sounds like it's just water flowing, but really fast. Usually patients with diarrhea, you hear that. Hypoactive, meaning that it's very slow. Sometimes if you don't hear any bowel sounds, that could suggest that they're having like a bowel obstructions, for example. So he had normal bowel sounds, very soft, pressed on it, is not big, pressed on it, there's no pain. Oh, EAC is, when you look into their ears, the external auricle canal, that's EAC, is clear, meaning that you don't see any redness, any swelling. Usually for patients with ear infections, you see swelling, there's like white debris on it. So EAC is that's what it stands for. Do I usually check everything on the physical exam? I usually, for emergency cases, I don't just do anything that's pertinent. For this patient, he came in for a lot of complaints, like upper respiratory, at the same time GI complaints. So that's why I had to do like ears, nose, throat, and heart and abdominal exam. And I had to check their to see if there's any like lymphatic issues or lymphadenopathy, which is swelling of your lymph nodes. So it's important to ask that because he did have a lot of like weird complaints, like not only upper respiratory, but also GI complaints. But if they're coming in for just sore throat or some ear pain, you don't have to check their stomach. You don't have to check, you don't have to check other areas to see if they have a rash. It just really depends on what they're coming in for. Okay, good. All right, so everything is, his heart is beating a little fast, but his stomach, abdominal exam, stomach is normal. His lungs were clear. His throat, even though he did complain of a sore throat, it didn't look red to me at all. So moving forward. So orders, what do I want to give him? So he is nauseous when he came to see me. And so I order 4 milligrams of Zofran ODT. ODT is oral disintegrating tablet. So what that means is that for patients who cannot tolerate PO, meaning they can't swallow the pills, you give them this because it dissolves on their tongue. It's a small white tablet that you put on their tongue and it just dissolves and they swallow their spit. And that helps. It's an anti-nausea medication and that can help with their symptoms. So I gave him that right away. And about 15 minutes later, he reports improvement in his nausea. We do have a rapid rapid flu test in the office. So that's definitely on my differential diagnosis. Differential diagnosis is a list of diagnoses that you think could possibly be for this patient, depending on their presentation and their symptoms. So COVID-19, definitely number one, right? All these symptoms and how prevalent COVID is, something to really consider. Number one diagnosis, COVID. Could also be flu-like symptoms. He has a fever, his heart's beating fast, he has GI upset. Flu can give you those symptoms as well. Or it could be gastroenteritis, stomach bug that could be causing this. He could be having an upper respiratory infections or even pneumonia. Whenever someone has a cough and they present with a low-grade fever and their heart's beating fast, pneumonia should always be on the list of differential diagnosis. Yes, CTA is clear to auscultations. Very good. Thank you so much for answering that. Did you do any blood work, UA, or chest x-ray? Okay, so my urgent care, we don't have any chest x-ray or blood work available. UA, I didn't really think it was necessary for this patient in particular. And so for blood work, we don't have anything like that available in-house. We would have to do it and send it out. For chest x-ray, his lungs sounded clear to me, and so I didn't think that it was necessary. I wanted to order other tests first before I bombard him with so many tests. If I had an x-ray available in the urgent care, maybe, but his lungs sounded really clear to me, and so that's probably wouldn't be necessary. So here's the plan. Here's what I did for the patient. I gave him, so he tolerated Zofran really well. So I prescribed him Zofran to go home with so that if he ever feels nauseous, he can take that as needed for his nausea to help him eat, right? Because it will be a cycle if they're not taking anything for their nausea. If they're feeling nauseous and they can't eat anything, and then if they don't eat anything, they become nauseous. So it's this whole cycle. So it's good to kind of give them something for their nausea. I also order a nasopharyngeal swab to be sent to the lab to test for COVID. And then I encourage him to rest, drink a lot of fluids, take small sips, do a liquid diet. Usually patients who present with diarrhea, I usually tell them to do like a liquid diet for 24 hours so that it can push everything out. And then after 24 hours, eat bland food, like start a brat diet. So if you guys want to write this down, you can look up the diet later, BRAT, but basically it's just bland food so that you're not eating like very heavy like steak or spicy food or anything like that could trigger the diarrhea. So, and then I also give him very strict ER precautions as well. So let's say that I discharge him, he goes home, he starts having like very bad stomach pain, abdominal pain, start throwing up more, having more diarrhea, his fever spikes, anything like that. Go to the hospital where there is blood work available, imaging available that can help further evaluate him. So this patient, we did a swab for him, sent it out to the lab. We got it back 24 hours later. He was indeed positive for COVID. And if you see the picture on the left side, usually it's how the lab will look. It would say the source is the nasopharyngeals. The result detected for COVID-19. Okay, and that's how the lab will look. And then like I mentioned earlier, I will go over the labs, send the medical assistant a message, and they will contact the patient and tell them their results. And usually I would send the medical assistant something like this for positive COVID patients. Call patient to inform him that he tested positive for COVID. 19, patient needs to continue to home isolate and stay away from others for at least 10 days from the day that they were tested, and it has been 24 hours without fever and other symptoms have improved, whichever one is longer. Okay, before I move on to the next case, I would like to give you guys a chance to ask me any questions for this case before we move on to the next case.
Just while you're waiting for those questions, that was a very interesting case, but kind of off topic. Congratulations on the Miss Asian America thing. That's so cool.
Thank you.
Yeah, what a very unique thing. Like we've never had anybody talk so much about their extracurriculars. So that's just really cool.
Super cool.
I think it's very important because PA schools want you to see that you have other hobbies outside of medicine, right? You can have this whole list of extracurriculars, organizations that you have been involved in, things like that. They really like for you to talk about. Even in interviews, they'll ask you like, okay, well, besides medicine, what do you do for fun? Or what do you like to do? So if you have something unique that you do, definitely bring that up.
Right. Yeah, that's kind of one of those interesting things is I feel like it's easy to forget about how you can tie in your everyday activities, like if you play a sport or something, into your application, right? Whereas PA schools really like to see that kind of stuff.
Yeah, definitely. So I see here some questions. When you do get these positives, how does it affect the clinic overall? And how often have you been seeing positive? Not sure what you mean by how does it affect the clinic overall? Like we're scared or... So when we get positives, I mean, we've been getting a couple months ago, we got a lot of positive, a lot of positive. Let's say we sent out 10 labs, we get like 8 back that are positive. Just an example, we sent a lot more, but it's just just so you know how much. It's like 80% of the labs we sent out were positive. Now though, it's definitely less. Right now, maybe I see in my clinic in particular, anywhere from 30 to 40% are positive. How does it, I hope I answer your question. How does it affect the clinic overall? I'm not really sure what you mean by that, but let me know if I answer your question, sorry. But okay, when you get a positive COVID test, do you need to report it to local health departments? Good question. So we don't. Whenever we send the labs out to Sonora Quest or LabCorp, they will report it to the local health department. And so we don't have to personally. But recently, my clinic just got rapid COVID testing available. And so for that, we know the results right away after 15 minutes. If the patient is positive, then we will report it ourselves because those are in-house rapid COVID testing, and we'll report it to the local health department ourselves. But the one that we sent out to the labs is responsible in sending the local department the results. Good questions. I'm really loving these questions. So are we ready to move on to the second case? Okay, does a staff also do a COVID test when a patient tests positive? So whenever a patient is tested positive, we don't test ourselves because we always wear PPE. We always ask patients to wear their mask whenever they're being seen in their car. We always wear full PPE whenever we go out there and test them. So unless a staff has symptoms, then yes, we do tell them to go home, isolate, and get tested. But if they're not having any symptoms, usually we don't test. Because imagine if we're seeing 40, 50 patients a day and like 30 of them comes back positive, and every day it's like that. We can't possibly test ourselves every day. It's just it's not practical. Like the number of testing is limited still, and we don't want to do that. So just kind of keep an eye on your symptoms and monitor your symptoms. And we wear full PPE, so that provides a lot of protection for us and the patients as well. And they wear their masks, so it's good. Okay, so I'll move on to the next case. Oh, sorry, there's 2 more. Do you need to get approved all your diagnosis by a physician before you prescribe medicine? No, you don't. You do everything yourself. And so if you come up with your you come up with your own diagnosis, you come up with your own plan, you prescribe whatever medication you think is the necessary for the patients, you call the shots. So you have full ability to see the patients, diagnose, treat them. Even for narcotics, pain medications, you don't have to get their approval. Are you required to get tested when you treat COVID positive patients, or are you required to get tested regularly? We are not required to get tested at my clinic. Like I said earlier, we only test the staff member or if they have COVID symptoms, but we are very, very careful. We always wear our PPE and we see patients in their car, so we're not exposed. How do urgent care clinics handle severe shortness of breath? Do they go straight to the ER? Great question. So patients who come in for severe shortness of breath, we see them right away. Let's say there's 5 patients waiting for something else and they come in and they're like, I'm having severe shortness of breath. We see them right away just because the level of acuity is higher compared to the other patients. And what I do is vitals right away. If their oxygen is low, if they're short of breath, but their oxygen is like 96, 97, they're talking normally, they're speaking in full sentences, then okay, it's not as concerning. Versus if they're panting, they can't complete their sentences. I've had patients who come in and it's like, oh, I can't, like, if they're speaking like that, then obviously they can't breathe, and you measure their oxygen, and if it's low, we do have oxygen available to give to the patient. So we'll start them on oxygen, and then we will call the ambulance to come and get them, because for those patients, if we take away their oxygen, they're just gonna go back to not being able to breathe. And so we just start them on oxygen, stabilize them, and then call the ambulance, and they'll come and get them, bring them to the ER, to the hospital. If you're not sure about the diagnosis and have to ask the attending, are they able to answer right away? So my clinic really depends on who you work for. My clinic, we have 3 attendings, supervising physicians who are at their own internal medicine office. And so they're only 1 phone call away. Like, we have our office phone inside our clinic, and so we just call them really quick and they'll pick up because they're working there as well. If they're with a patient and they can't get in, and they can't talk to you, there are 2 more that you can contact. If all 3 are busy, then you would try your best to make the best judgment that you can. And usually that rarely ever happens, that all 3 are busy. Usually if 1 is busy, the other 2 is not. Or if 2 is busy, the other one's not. So rarely do all 3 are busy. But I know that there are other clinics where there is only 1 supervising physician. So that might be tough if they're not on site with you and they can't answer your text. So when you apply for the job, very important to ask the supervising physician about their availability and if they're able to answer your text or your call right away, because if they're not available, that could be an issue. Okay, we'll move on to the second case. This is a little bit more interesting, different procedure case. So this one I saw actually recently. A patient came in for a left hand laceration. So you can see the real picture, and I got his permission to do this presentation before I took a picture and put it on this presentation. So it's all good. HPI, 30-year-old male presents to clinic complaining of laceration on the left hand that he got an hour ago. Patient states that he was trimming trees when his hand slipped and he accidentally cut himself with a trimmer. Laceration is located on the medial side, so this side of the left hand. Reports bleeding at onset, and he has been controlling it with a towel. Patient reports tenderness at wound site, denies numbness, tingling, still able to move all fingers and left hand and left wrist, denies any bleeding disorders. Last tetanus shot, unknown. Okay, so this patient came in for a laceration. Laceration, fancy term for a cut on his hand. It looks pretty bad. If you can see the picture here on the left side, pretty deep cut. And yeah, you can't really see a cursor, but basically that little flap in the middle at the tip, there's actually another cut at the tip. So that piece, that flap was so thin that it was actually, was going to be, I knew at the beginning that it was going to be really hard to suture this patient up just because how thin the flap is. He wanted to go to the hospital, the ER, but he's a self-pay patient. And so for self-pay patients, they don't have insurance and it's going to be really expensive for them to go to the hospital. And so he went to the urgent care instead. And I told him that I am able to do this, but it's going to scar just because of the presentation of the cut. Okay, objective. So everything, I'll go over what's important here. If you have like the previous case, if you have something that you are not sure about, you can always ask me in the comment box and I'll answer. So skin, you always want to describe like how the cut looks. So this one looks kind of like a U. So I put U-shaped laceration. I've had lacerations that looked like a V shape as well, or just like a linear laceration. So those you can just like describe them the best that you can. U-shaped laceration that is approximately 3 centimeter by 3.5 centimeters. So you just measure them, just measure that U shape. Located on the medial side of the left hand. So again, this side, right? No active bleeding, no foreign body. On visual inspection, sensation intact, no tendon involvement, wound edges come together, normal left wrist and fingers, full range of motion in all directions. So FROM is full range of motion. So for this cut, you always want to describe it. Any active bleeding, is the patient constantly bleeding? That's good to know because if he's been bleeding for like an hour, that's something to look into, right? So this guy, he was able to control it with his towel that he compressed himself with. So there's no active bleeding, as you can see in the picture. No foreign body. When we cleaned it, we try to look for any foreign bodies at all. We didn't see anything that on visual inspection. Sensation intact, so he could feel all of his fingers. He didn't have any like numbness and tingling. He didn't have any like loss of sensation. Important thing to look into is the tendon. Is it showing? Because if it's showing, you might have to send him to the hospital to do imaging. But in this case, it wasn't deep enough for that to show. Wound edges, do they come together, or sometimes a patient gets a cut and there's no flap like on top, so you can't really pull the skin together. You can't do a suture over that. You just have to kind of let it heal by itself. For this patient though, the edges do come together, so you can suture them back up. The only issue is that the flap was so thin that I wasn't sure that I was able to do it. But he still wanted me to try because he didn't want to go to the hospital and pay such a large amount of fees because he's self-pay. Always want to, always, of course, do like pulmonary exam, cardiac exam, make sure their heart and lungs are normal. Vascular exam is important. Make sure to check their pulses on their hands, make sure they're on their wrist, make sure that they're normal. And make sure that all the joints are able to move all their fingers, no swelling anywhere else. Okay, so left picture are the supplies that I usually gather before I do my suture. So assessment, laceration without foreign body on the left hand, initial encounter. It's good to put that down, because the next person can, the next provider who, if he comes back, the patient, if he comes back for a follow-up, it's good to know if this is his first time here or second time or third time. Plan, suturing, location, left hand. So at first you want to clean the area really well, irrigate it multiple times with sterile water and HEPA-Cleanse. HEPA-Cleanse is like an antiseptic solution, and you just clean the areas, the wounds. Yeah, cap refill for 2 seconds. So cap refill basically check the flow of, so what you do is you check the blood flow, and if you press on your fingers like this and it turns white and then you let go and it goes back to the normal color, that's normal. So that's like cap refills less than 2 seconds. So that's what I meant by cap refill. So that means that the flow is normal. So that's basically what it means. So after you clean the wounds with HEPA-Cleanse and the sterile water, irrigated multiple times. Okay, let's see. Oh. Okay, so after you clean the wounds, you have to numb the patient. And numbing is the worst part in this procedure because it's the most painful part. I always tell patients, like, this is the worst part. Once you pass this, you won't feel a thing because you're numbed up already. So what I like to use is 1% lidocaine. There's 1% and 2%. And there's with epi, there's one without epi. So 1% is generally enough. I rarely do use 2%. Patients, really just depends on the patients. If I do 1% and they're still feeling the pain, because patients process lidocaine differently. And so some patients need a higher dose of lidocaine. So I'll use the 2%, but rarely do I use that. Generally 1% is enough for most patients. Without epi or with epi, someone asked, yes, hello, can you please explain what happens if a patient does not have insurance? So if a patient doesn't have insurance, they just pay a self-pay fee, which is $120 at my clinic, but it could be different at other clinics as well. So let's say this patient, he was a self-pay patient. He didn't have any insurance. So he came in and we charged him $120. $120 to be seen, and that's included with everything that we do in the clinic and all the tests and all the labs. So that's the 120 is for the whole visit. Do you ask why or redirect them to the government for assisted medical programs? For that, my staff in the front desk will sometimes ask if, like, give them programs and offer them programs that help uninsured patients. But I usually don't talk to them about it just because it takes a lot of time, and we're usually very busy, and so we try to get through the patient as best as we can. But my front desk staff will usually talk to them about that. What is epinephrine? Yes, epinephrine. So back to our case. The lidocaine can come with or without epinephrine. So when do you use with epi? When do you use without epi, right? So I usually generally use without epi. I only use with epi if I think that the patient really needs it, because the epi helps it last longer and work better. Generally, I don't use it. And also, if you have a laceration on the fingertips, I don't use epi because in PA school, you will learn that you don't use epi for fingertips, toes, nose, and penis. And so those are the areas that you don't use epi in. Generally, I don't think patients really need epinephrine with the lidocaine, so I generally just use it without. Okay. And so after you numb them up, you make sure you go through the edges, the skin edges, and you numb them up. I usually test it out before I start suturing. Like, I'll use the same needle that from the lidocaine, and I'll try to poke them, and I'll ask them if they feel anything. And so this particular patient, 8 cc. So cc is basically the same as like milliliters. So basically 8 milliliters. We used a syringe. If you see on the tray, that syringe is 5 cc, so 5 milliliters. He needed a little extra because he wasn't completely numb. And so we used a total of 8 cc on him. So 8 milliliters of lidocaine on him. And so after he's fully numbed, I will start suturing. And I have a video in the next few slides to show you how I do it, just a short video. But basically I put 10 stitches, interrupted sutures. So there are different kind of sutures, right? Interrupted mean that you suture them one suture, and then you cut it, and then you do another suture. So that's why it's called interrupted, because it's not consecutive. If you learn later on, there's different kind of sutures. There's like the running sutures where you continue, you don't cut it, you just keep doing it. But there are different kind of sutures that you use. I feel like interrupted will work better with this kind of cut, this kind of laceration. So I did that. After that, you give them instructions. You put bacitracin, which is an antibiotic ointment, on their skin, and you wrap it up, and then you give them instructions. Keep it on for 24 hours. The reason why you do that is, someone asked, what do you use if the patient needs to be numbed, but maybe allergic to lidocaine? Usually you ask them what their allergic reaction is. If it's like, because usually it just depends on, you have to weigh the risks and the benefits. If they're like, oh, it gives me a rash for lidocaine, then it's like, okay, that's not a good idea for us to use it. If someone's like, oh, sometimes when I use lidocaine, it just makes my stomach hurt a little bit. So it's for patients like that, it's like, okay, well, that's not really a large side effect. For patients with rashes or can't tolerate lidocaine, you have to look into other options, like maybe something like topical. For lidocaine, rarely do they have an allergic reaction just because it's so localized. You're giving them an injections in a localized area. So oftentimes they don't have that, excuse me, reaction. So excited. Yes, graphics, yes. Okay, so after you're done suturing them, you will give them instructions. Keep the bandage on for 24 hours. The reason why they have to keep the bandage on, excuse me, for 24 hours is because sometimes when they're bleeding, it's good to have pressure on their wound so that the wound can start healing. If they take it off before then, the wound might open, there might be some bleeding involved. And so I like to tell them to keep it wrapped for 24 hours so that we can make sure that your body has time to start the healing process and the bleeding can stop. And then after that, they can take it out and wash it gently with like an antiseptic soap, or even if they don't have that at home, they can wash it with like warm water and a gentle soap. And then after they wash it, pat it dry, and then put ointment on it, and then put like a non-sticky adherent pad on it. I don't recommend using like those gauze that are netted woven, because those can pull onto the sutures and can possibly even rip the sutures. So I usually tell them to use like a non-adherent, like those non-stick. I wish I brought home examples to show you guys. But if you can see in the picture, it's the left lower corner. It's that little small pad. It's not, if you can think of like the bandage, that little white piece, it's like non-sticky. It's like that, but bigger. So that's what you put on the patient. Okay. And then of course you always have to give them ER precautions. If they start developing significant swelling, pain, redness, drainage, fever, go see someone immediately. Either go back to the clinic or go to the hospital, because that means that they have developed an infection. Generally, yeah, telfa is okay. Telfa, someone said telfa. Yeah, that's okay as well. As long as it's non-adherent, like non-sticky. So generally for lacerations, you don't prescribe them antibiotics. Generally, they don't need it. They don't need it unless you look at the wound and it looks really dirty. But patients often don't need antibiotics, but you have to give them instructions. If it becomes infected, like painful, swelling, redness, anything like that, then you would have to have them come back to start on an antibiotic or go to the hospital. What if the patient is unsure if they're allergic to the drugs or not? That's a hard question. So sometimes if they're not sure if they're allergic to a particular drug, let's say that I want to prescribe them an antibiotic and they're like, oh, I've never taken this before. I'm not sure if I'm allergic to it. I usually will, if they know, like, oh, when I was little, I think I was allergic to something, but I'm not really sure what, I'll have them like ask their family members, their mom, to be sure. Or sometimes patients have an allergy, but they just don't remember what, but it's in their records somewhere. I'll ask them what pharmacy they usually go to, and I'll call the pharmacist myself, and I'll ask them what drug allergies they have. For patients who's never taken anything before and they're not sure if they're allergic to something, I usually will prescribe it, and then I'll have them give them strict ER precautions. Hey, take this medication. If you start feeling like you can't breathe or you start breaking out in hives, things like that, go straight to the hospital. And sometimes, like, if they live near a hospital, I sometimes just joke and tell them, like, you can probably take it out right outside of the parking lot of the hospital, and if you show allergic reaction, you can just go straight to the ER. But it's hard. Definitely, if they've never taken anything before, like, you just have to kind of give them strict precautions. Okay, so this is the video that you guys have been excited about, so I'm gonna play it. So before I play it, I'll explain what I'm doing in the video. So for suturing, when you're doing, it's called throw. So you want to form a knot, right? A knot consists of many throws. A throw is basically when you're when you're doing this motion where you're tying. Like, a throw is more like how many kind of ties you're doing. And for me, I usually do 3 throws total for each suture, for each knot. Okay, so I had to mute the video because my patient was like talking and laughing because I told him that I was gonna record to show you guys, and he was like, why aren't you showing my face? I want to be in it too. I don't want my hand to be in it only. And so he was laughing, and so I just having a full-on conversation, so I had to mute it. But basically, as you can see, I'll replay the video again, but this motion, I wish I brought like suture and like the supplies home to show you guys, but basically I'll just pretend. I'll just use a cord and I'll pretend. Okay, so let's say this is my suture, and so basically you use a needle and you go through one edge and then you go out the other edge. And then the first initial knot that you're tying, you're gonna do 2 loops and then you tie it. And then the second one, you do just 1 and then you tie it. So that being said, I'm sorry if I'm not making a lot of sense. I wish I brought home the supplies to show you guys, but maybe next time. I will play the video again and maybe you can see what I'm talking about. Okay. All right, so moving on. So this is what it looks like after. So you guys saw the before picture. This is what it looks like after I'm done. I put 10 in there. This is the best I could have done because the skin was so thin. The flap was so thin that it was hard to approximate the skin together, meaning that put the edges together. So I did 10 sutures there. And after you suture, you always want to move it to the side so that later on, whoever, ignore the picture on the right side. That's something else I'm going to talk about. But the guy with the laceration, our patient, is the picture on the left, and that's after. So you always want to move the knot to one side. So later on, whoever has to remove it, it'll be easier for them instead of the knot being in the middle and in all different directions. So that one is a harder case to suture. Really depends on your comfort level. I know a lot of my colleagues don't like to suture cases like this because it's so hard. It's really hard to kind of pull the skin together and how thin it is and the location too. It's kind of awkward, and it really depends on your comfort level. I know if you are not comfortable with suturing something like this, you can always send the patients to the ER to have it done. But like I said, I wanted to do what I could for this patient because he didn't have insurance, and he was okay with it not looking well, I told him, like, compared to a hand surgeon, of course, it's not going to be comparable to the hand surgeon, but I'll try my best. And he was okay with that. The one on the right is another patient. I wanted to show you something more simple. It's like a straight laceration. So as you can see, like the the suture looks more in place and it's more even. So that's a nicer and more, it's like a easier laceration versus the one on the left is more complicated. Someone asked, what's the most severe bodily injury, open wound have you seen and resolved at an urgent care and not at the hospital? I had a lady who was in her 70s who came for a very large laceration on her arm. So basically she had like a V-shaped laceration. It was so big that you can literally lift up the flap and see everything. And you know how elderly patients, their skin is so thin that I knew it was going to be hard to suture her because their skin was so thin. But I did it because I was comfortable with it. So I put 14 sutures in her and it healed. I wish I took a picture of it, but it healed beautifully. Like when I follow up with her, the scarring was great. There was no signs of infections. It healed up very, very well. I was very happy with the results. But really, I mean, if you're working at urgent care, you're by yourself, it can get really overwhelming and it can be really scary. I just recommend like not pushing yourself to do something that you're not comfortable with. Only do it if you're comfortable with that particular injury, because at the end of the day, you want the best for the patients and you don't want to do something that is out of your comfort zone. Does your suture affect your workflow at the urgent care? Great question. Yes, it does. Because suturing takes a long time. This one took me maybe 30 minutes because the patient, he needed a lot of lidocaine. He wasn't numb. after like I gave him like 1 injection. So that's why I had to pull a second injection. So that does slow down the flow, because for urgent care, I usually do 15 minutes per patient because we do see a lot of patients. So that day we had 40 patients. And so I had to take out time to do this laceration, and it took me 30 minutes. But I've done a lot, so I'm a little faster. I've had colleagues who needs at least like an hour to do a laceration, but since we are also a walk-in clinic, it can slow the flow down. And so patients would end up waiting and they would get upset. But most of the time, all we can do is try our best to explain to the patients, like, sorry, like we just have a patient who needed more time. So that is why, your wait is a little longer, but it does slow down the flow. What are different suturing techniques? Are all sutures the same? Great question. Yeah. So I want to talk about this patient, so suture comes in different size. So it's funny because the higher the number, the smaller the suture size. For this patient, I use a 4-0 nylon. So I'll go over the different types of suture as well. But basically, for any arm extremities, you can use like 4-0 or 5-0, which is the size of the suture. If you use like a 1-0, that's a really, really big suture. A 10-0 is like very thin, like a hairline. So you can see that with like, vascular surgeons will use those because it's so thin. But usually, generally, you use anything from 3-0 to 6-0 in a traditional clinic. For this patient, I use a 4-0. It really depends on your judgment too. When you're practicing, if what kind of suture you need, what size. Also, different types. There's absorbable and non-absorbable. So absorbable, you will have to go under the skin and do like a subcuticular, meaning that you have to just do it underneath the skin and bury the suture. So those ones I saw a lot in my derm rotation. So it does give a better cosmetic result. Like the scarring generally is better with absorbable from my experience. But for this patient, like there's no way that I could do like absorbable suture because the skin was so thin, and there's no way that I could go underneath and bury the suture. So I had to do interrupted. I also mentioned like running suture. So that one you don't do one suture and then you cut, and then the second one, that one you continuously do like suture the patient. It's kind of like if you look at the suture on like a baseball, that's something, it will look like something like that, like a running suture. I hope that helps. Okay, so some other conditions that I also see at an urgent care. I know we only have time for like 2 cases, but some other conditions includes abscess. Oh my gosh. So if I do ever have another abscess that I have to do incision and drainage, I will record that and maybe I can come back and show you guys, because I love like Dr. Pimple Popper. So I love stuff like that. Anyone else the same? So I've had patients who you're able to express, who have a big abscess, and you have to laceration. You have to do incision, meaning like a small cut, and then you drain it. So you squeeze it out, squeeze all the pus out, and it's very, very satisfying to get all that gunk out. And the patients feel so much better too. So that's a really cool case. I see that a lot at the urgent care. Next time I'll for sure ask the patient so I can record it, and then hopefully I can show you guys. I also see like skin conditions, fungus infections, ear infections a lot, insect bites, dog bites, migraines, back pain, rashes, skin infections or skin conditions, sprains, strains, closed fractures, STDs, UTIs, urinary tract infections. So we see a lot of that too, STDs and UTIs at the clinic. So those are some other conditions that I see, but we don't have time to go over them today, unfortunately, maybe in the future. but I'll definitely keep in mind, everyone's saying they love Dr. Pimple Popper. Yes, she's the best. Okay, so some advice for pre-PA students, for you guys. My biggest advice is that, what is your mission? Think about that. Why do you want to go into medicine? Why do you want to go into PA, the PA profession? Think about the theme that you're going to have, because you're going to have to talk about it in your personal statement applying for PA school. You're going to be talking about it during your personal, your interview to PA school. So think about that, have that common theme. For me, it was helping the underserved. And then my struggle with my family, with financial restrictions, and working for patients, or providing care for patients without any insurance. And so that was my mission. What is yours? Think about that. Second tip, start early. If you know, which I'm sure all of you know, that you want to become a PA, start early. Start working on those clinical hours, and then start shadow as many professions as you can, PA, MD, DO, NPs, etc., because that gives you the ability to compare. Let's say in PA school, during the interview, they will ask you, why PA? Why not MD? Why not DO or NP? You can tell them, hey, I did shadow an NP, I did shadow an MD, and it's not what I like, it's not what I want to go into. PA is the profession for me because of so-and-so. So you can compare, and you can say that you've done it all, you shadow them, and it's just not for you. So that gives you more strength in your application, and when you during your interview. Network. Social media is such a great way for you to utilize it in a positive way, to network and to reach out to these PAs, ask for shadowing opportunities, or even have like a one-on-one conversation with them, ask them about the process to apply. And when you do get an interview, reach out to those PAs and ask for a mock interview. That's what I did during my time applying for PA school. No shame, I reached out to a lot of people, and I was like, hey, can you please do a mock interview with me? Help me, give me some tips. And I'm going to say it here, I'm available. You can send me a message on my Instagram, and I would be more than happy to do a mock interview with you and just give you tips on what to say, or what questions I was asked, things like that. Take a gap year if you want to, if you need to. I didn't, but I know a lot of people who did, and you have your whole life in front of you to work and work and work. And so taking 1 gap year, 2 gap years, and 3 gap years is not gonna be a big deal if you think about it. I know a lot of students come to me and they're like, oh my gosh, I'm gonna take this gap year, it's gonna look so bad on my application. No, as long as you utilize that gap year to your benefit. If you tell them, I took a gap year and I worked in this area, I did research, or I did this, I did that, it's gonna make your application look really good. So don't be afraid to take a gap year if you need to. And also don't compare yourself with other people. If they're not taking a gap year, that's them, but it doesn't make your chance of getting into PA school any less. Don't be afraid to apply. I also have a lot of students who have all their hours, have all their materials, but they're just scared. They're scared because of the results. If they don't get in, if they don't get offered an interview, I say just do it, just apply. You never know unless you try, and apply to a lot of programs. When I applied to 10 programs. And so I recommend, if you have everything set, just do it. Just apply. The worst thing that could happen is you not getting in, but if you don't apply, then for sure you're not going to get in. So shoot your shots and yeah, apply. Okay, so I feel like I talk so much already. So this is a chance for you guys to ask me any questions if you have regarding myself, my hours, anything at all. If you forgot, if you had a question about the case and you forgot, you can also ask me too, and I'll try my best to answer it. And then I also have, I listed my information, contact information on here as well. My email, notvivo93@yahoo.com. So you can email me if you need something. But the best way to reach me is through my Instagram. So you can send me like a message and I would definitely answer you, reply to you. Just follow my page and send me a message. So I'm gonna look at the questions now. Okay, I love Dr. Pimple Popper, yay. When in PA school, do you get to choose your specialty? You can choose your elective rotations. So there are, when you're in PA school, there are a set of of rotations and specialties that you have to rotate in. For example, internal medicine, family medicine, emergency medicine, OBGYN, surgery. So those are the psych. So behavioral health. So those are required rotations that you have to do, but then you get different programs different, but my program, you get 2 elective rotations. So that one, you can choose whichever specialty that you want. Let's say that you really wanted to go into emergency medicine. So you can choose to do emergency medicine again for your elective. I chose dermatology twice because I wanted more time, and I want to explore that specialty. So that's what I did. But different programs different. So I know some programs don't allow you to choose an elective rotation. So it's important when you're applying for the program to look into that. I know when I applied, Drexel didn't allow an elective rotation. They were primarily focused on primary care. And that was like, I got accepted, but that was the reason why I didn't want to go into the program, because I wanted to explore other specialties as well. And I felt like they didn't allow me to do like dermatology. And so that was one of the reasons why I didn't choose the program, even though it's a really, really good program. Are diabetic patients allowed to receive sutures? Absolutely, that's okay. If they have a history of diabetes and their diabetes is controlled, they're taking their medications, I don't see why not. I mean, suturing will help with the healing process. So yes, absolutely. What are your ways to be competitive for PA school? To be competitive, I would say top 2 things are your GPA and your clinical care hours. So when I applied, some of the programs said that, oh, we don't even look at applicants with a GPA less than 3.4. But that's just some schools. There are so many PA programs available. But I definitely think GPA is very, very important. But don't be discouraged if you have a low GPA, because I know people who have gone in with GPA as low, like GPA around 3.1 or even 3.0. And so don't be discouraged if you have a low GPA. I would suggest, though, if you have a lower than 3.0, retaking some classes to boost your GPA up would be good, because I would recommend keeping it around 3.4 if you can, but if you can't, then try to do it above 3.0 at least. Oh, and then another way is clinical hours. The more you have, the better, because in medical school, you don't really need patient care hours to get in. And so they get their training through medical school and residency. For us, we get our education, and then after that, we go and practice right away. So it's very important for PAs to have as many clinical hours as you can, so that once you are done with PA school, you can start working right away, and you have that knowledge-based clinical hours to use. Did you ever consider doing the National Health Service Corps? No, I really didn't look into that. I know a few people did consider doing that, but personally I didn't. I wanted to stay, I wanted to do a program near where I was living at the time, which is Jacksonville. And so my top program was the NSU NOVA Southeastern program. That was my number one choice. So I didn't really look into that. I'm sorry. I know many schools prefer for students to have an in-person shadowing. How do you recommend we do this in this uncertain time where many clinics have no visitors at all? I know it's during this unprecedented time, it's so hard to get in-person clinical hours, but I personally offer students to come into my clinic and shadow. So if you are in the Arizona area, Phoenix area, definitely reach out to me. I can possibly set something up for you to come into my clinic and shadow me. You get to see a lot more procedures for sure, and a lot of hands-on cases in clinic. But if you are living somewhere else, definitely reach out to the clinic itself. When I was looking for shadowing opportunities, I looked up the PAs around my area and I sent them an email. And believe it or not, some of them did reply and said, oh, hey, why don't you come and meet me for a second, or for a little bit, so that I can see why you're interested in shadowing me, etc. And so definitely compile a list of PAs around your area, of the specialties that you're interested in, and reach out to them, email them, or even call the office, or you can even come to the clinic and drop off your resume. I think that's a great idea, to go to the clinic itself, drop your resume off, and tell them like, hey, I'm a pre-PA student. I'm very interested in the PA profession. Can you please let me know if I can come in and shadow you, if that's possible. Does explaining that I shadow different nurses during high school count in an interview? Absolutely. I think you should definitely mention anything that has to do with like you volunteering. I volunteer at a hospital during my high school years, and I brought that up during my interview when they asked. It's like, it all started with high school when I shadowed these people. I worked here and there, and you can connect all your experiences together. I think mentioning anything that has to do with your path to becoming a PA, there's nothing wrong with that. I strongly recommend that, actually. As an undergrad, would it be a good idea to get certificate in MA or other fields for patient care hours experience, healthcare experience? I just did CNA, Certified Nursing Assistant, because I felt like it was the shortest amount of time, shortest amount of training compared to other areas like phlebotomy. I think it takes like 4 to 6 months. For medical assistants, it takes like, some programs takes 1.5 years for you to be certified. Like EMT, same thing. It takes months for you to be certified to become an EMT paramedic. And so I found that CNA was the shortest amount of time. And so that's why I chose that. But definitely, it really depends on you. But make sure that it counts as patient care hours slash healthcare hours for the program that you are applying to. 1 second, I'm going to charge my laptop. Oh, my laptop's dying. I still have a lot of questions here. I know that it's 8:49. 1 second, sorry. I'm going to charge my computer really quick. Okay, sorry about that. Okay. As an immigrant, how diverse was your PA school? As a minority in the medical field, have you had any diversity? diversity issues, discrimination as a PA. Great question. I love that. Yes, I have had a lot of situations where I had to deal with as not only an immigrant or person of color, but also a female being in medicine. I've had patients who called me like racial slurs even, or patients who refused to see me because I looked because I was Asian and I was a female and I looked young. How do I deal with situations like that? I think trying to understand whenever patients are rude to you, always try to understand where they're coming from. Patients who come to you are very sick, and so they don't feel well. And sometimes they can come off rude or abrasive. So try to understand that. But when it gets to the point where they're saying like racial slurs and they're very combative and they just don't want to see you because of the color of your skin, I think that's where you should draw the line, and you tell them that if that's how they feel, then they should leave, and you don't have to treat them and you don't have to see them if that's how they feel and if they don't want to be seen by you because of that. Because at my urgent care, I'm the only provider there. So if they don't want to see me, then there's no other providers there. So yeah, I just kindly asked them to leave. But I did have situations where patients, one particular patient yelled at me and called me racial slurs. And then we asked him to leave, and then he didn't want to leave. So we had to call the police, and then we got the police involved, and the police had to escort him out. So you will have to deal with situations like that. Well, hopefully you don't have to deal with situations like that, but you might have to. How did your expectations of being a PA is like before and after becoming one, and what was different? I shadow a lot of PAs, so the expectations were, the expectations are the same, but what I didn't expect coming into this profession is being hit with the pandemic. I think nothing has prepared us for this COVID pandemic during PA school. I think we were never really taught how to deal with this. I remember a couple months ago when we were seeing 50, 60 patients a day and COVID patients a day, it was very tough on me mentally. I was, to be honest, like burnt out at one point because of the amount of patients I was seeing daily. We open at 7 a.m., right? You guys know. But when I got to the clinic right at 7 a.m., there were 20 patients lined up in front of my clinic waiting to be seen already. Some of them even brought their like camping chairs and like tents because they've been waiting there since like 5:30 to be seen, because it's like first come, first serve. So a couple months ago, we're still very limited on the number of testing that we have. And so it's we can only take like 40, 50 patients a day. After that, we're out of test. So patients would come early and they would line up in front of our doors. And some told me they came at like 5:30 or even 5 o'clock in the morning waiting, which is so sad because I feel like everyone deserves a chance to be tested. And like, how do you turn patients away? How do you determine who to test and not to test, And so at that time, it took a lot. Excuse me, it was a lot on me mentally, like my mental health. I was having anxiety and depression because of every day I come home and I'm just exhausted. And so that's like I guess like the bad part about being in medicine, because sometimes you have to be careful not to burn yourself out. You have to have a strong support system. So I reached out to a lot of my colleagues at the time and I asked them like, hey, how are you dealing with this during this pandemic and the amount of patients that you're seeing? And a lot of them were glad that I reached out to them because they were like, oh my gosh, you too? Like I was scared to talk about it. I was scared to talk about my mental health because being in medicine, you feel like you have to put on this front, you have to pretend to be strong all the time so that you can provide for your patients. But you have to care about yourself too and your mental health. And so having that strong support system is very important. And so I got through that tough time because of that, because of them and because of my family and friends. And so that's something that I did not expect going into medicine, being hit with this pandemic and having to deal with that. Hope that answers your questions. Okay. What other specialties did you consider? I considered dermatology, and to be honest, I really love cosmetics and dermatology as well. So maybe later on, that's the beauty of being a PA, right? You can transition to specialty, any specialty that you want. And so I think I really love my job now as an urgent care PA. But down the line, I might do like part-time in dermatology. Do you feel like PA school prepare you for the job, or did you learn most of your skills on the job? That's a very good question. I get asked this question a lot. I felt like PA school really depends on the program that you're in, but my program did prepare me well for the medical knowledge. So the medical knowledge is there, but it's really up to you to apply it towards the cases that you see in clinic. Do the patients present like textbooks? No, they don't. You will have to go with your medical judgment. A lot of them present atypically, meaning that they don't have the typical symptoms that you would see in a textbook. So in a textbook, you would see, oh, the patient will present with this, this, and this. But when you're practicing, you learn that sometimes the patients will present something that's completely different, and it's up to you to order the right tests, the right labs, and have the right judgment to make that correct assessment, diagnosis, and plan. But yes, my program prepared me well for like that, to have that medical knowledge, that foundation. But I did learn a lot more practicing it and applying it towards the patients. For a new grad, would you recommend urgent care or emergency room if they wanted to be somewhere fast-paced, but where do you see a little bit of everything? So urgent care, if you see a lot of cases, and if you are not sure about case, or if it's something that you think that, oh, I don't have enough information to rule out a dangerous diagnosis, you can send them to the hospital, the ER. And then if you see a condition that just needs to be follow up, you can send them to their primary care doctor, and then they can follow up with them. So you're like the middle person. It's like, okay, does this person needs to be at the hospital, or does this person, I can put a Band-Aid on over it and they can follow up with their primary care doctor. So that's what I like, is being able to like be that middle person to dictate or to decide where they need to be seen. But if you like something where it's more, the conditions are more severe and you have more, you can find out the answer right away with labs available and imaging available, definitely try emergency medicine, because you have a lot of like PAs working there as well. You have a lot of physicians working there. You have your labs available, imaging available. And so you get a lot of your answers there, versus urgent care. We don't have a lot of that. And so if I send them to the hospital, I don't know what they were diagnosed with, unless I call them and ask them. So are you considering switching specialties? So yeah, maybe to dermatology. What factors did made you decide not to work in dermatology? Because I wanted to go into something that will help me solidify what I learned in PA school. So let's say you finish PA school, you have all this knowledge that you need to put the knowledge with the patient. If you go into dermatology, all you see is like skin rashes, skin cancers, maybe Botox, fillers. You won't get like a heart attack, or you won't get like someone with like an ear infection, or even what you guys saw, like diagnosing someone with COVID symptoms. So I wanted to start with something that has a lot of medical conditions, so I'm exposed to a lot, and I can use my medical knowledge and solidify my medical knowledge before moving on to a specialty. What do you think helped you stand out in your application? I think definitely my goal and my story and my theme, it was what stood out to them because I was so passionate about helping the underserved. And if you look at their mission statement, a lot of the program's mission statement talks about helping the underserved. And so I think that's what made me stand out because my mission aligned with theirs. Do you currently have an in-person shadowing? Yes, I do. I do have an in-person shadowing opportunity. I recently accepted one student so far, but if you're interested and you're in the area, definitely reach out to me and I can hopefully help you set something up. Do schools focus on science GPA or just overall GPA? When I apply, they looked at both, but I think science is a little bit more important than overall, but they definitely look at both. Do you know any international students who pursue PA? I'm currently an international student. I'm kind of stressed and discouraged sometimes because of many disadvantages that I have. Okay, don't be stressed, but international students who go into PA, I do know a few. Yeah, I do know a few international students who have gone to PA school, but none of them were my classmates. It's just friends that I have. So definitely, yes, compared to a non-international student, yes, that is a disadvantage, but hey, don't let that stop you. Like you can still work, get that hours, get a good GPA and apply. Yeah, definitely don't let that discourage you, okay? I will literally fly to you. Okay, yeah, let me know. I will. I've had mentees who flew to me from Florida to shadow for like a week, and she stayed at an Airbnb, and it was a great experience for both of us because she got to see a lot of cases that were cool. So yeah, if you're able to fly here, let me know. I am happy to set it up for you. I know this doesn't fit your experience, but any advice for later in life applicants who are already have an established healthcare career and not applying straight out of school? I don't see why not. Honestly, my classmates, I've had classmates who were working as an engineer or even like a nurse that applied to PA school and they worked for a while. And I've had a classmate who was actually like in his 60s and was still going to school for PA school. So definitely not, you can start anytime. And what advice I would give is make sure you have all your prerequisites because I know it might be a while since you've been in school. Make sure all the classes are qualified. Because I think some of the applications require you to have those classes within 5 years or something. So make sure you have all the prerequisites, make sure your GPA is good, and make sure you you have enough clinical hours to apply to those programs. But I don't see why not. Someone says she's such a great teacher. Oh my gosh, thank you so much. I just started mentoring students, so that's a really great compliment. I hear it's common to apply to urgent care and have one, maybe two providers, but always hear of a huge daily patient load. Why don't they have more providers? You know what? I ask the same questions every day. I think mainly because the company doesn't really want to, I think they, just mainly because of like business reason. I don't think they want to pay for like 3 providers at the urgent care or even 2. It really depends on the patient load. I know that there are urgent care that has 3 providers, but their patient load it's like 100 something. So each one still has to see like 40, 50 patients a day. Thank you for sharing the cases. Okay. Scribe, yes, Scribe is a good option. My brother is actually doing Scribe right now because he wants to become a PA. But be careful with Scribes because some programs don't count that as like direct patient care hours. So make sure you check with the program before you start your Scribe job. Someone asked if I had an Instagram. Yes, I do. Vivo_PA. I have a lot of questions. Okay, sorry about that. I think there's a lag. Talk about rotations PA school, how we were taught. Yeah, so first year is didactic year. So you are in class, you're taking courses. Your day is usually like from 8 to 5, and then you Monday to Friday, and you take all your courses. Second year is where you start your rotations, your clinical. So that one is you start off with a specialty. For example, I started off with pediatrics, and so I did that for 5 weeks. Some rotations would be longer, like 5 to 6 weeks. Some would be shorter, like 4 weeks. And so you would do that for the second year, and then after that, for the first year, you take a lot of tests because you're taking classes. For the second year, you only have one exam per rotation. So after you do your rotations, you come back to the campus and you take your end of rotation exam. And you have to get a 75 or above to pass that. If you get below that, then you would have to talk to the program director on what to do next. I've had classmates who failed out because they didn't pass their EORs, end of rotations exams, and so it can be really stressful. I'm interested in doing pediatrics, but I haven't heard much about it from PAs. Do you know anything about specialty, or if it exists for PAs to work? Of course, yes. You can literally work in any specialty. So you can literally, become a PA and then work at a pediatrician office. I have a lot of friends who are who have found job as a pediatrician PA, or PAs in pediatrics, sorry. Do you have enough time to finish charting when you're working at urgent care, or you bring it home? Sometimes I will have enough time to chart because I have templates. So I just like click on the templates and then import whatever I need to. But sometimes if I'm seeing like 40, 50 patients a day, no, I don't have time. I'll have to bring it home to work on my days off. So if I'm working like 3 consecutive days, I'm not gonna work at night when I get home because that's too exhausting. I would just de-stress, watch shows, and then work the next 2 days, and then then I'll work on my notes and chart during my days off. Okay, so yeah, I think I answered all the questions. If you have any additional questions, or if I didn't see your question or I skipped over, I am so sorry. Like I said, you can also send me a message on Instagram. I will try my best to answer them. I usually go through them all and answer all the questions. And so if you are interested, and also if you're interested in shadowing, you can also do that. You can also reach out to me. And someone mentioned flying here as well. So, hey, reach out to me and maybe we can set something up. Yay, thank you.
Thank you so much, V. This has been so fun and super informative. We really appreciate your time. And adding that video was so cool. It was really fun to watch.
Yeah, thank you so much for inviting me. It's such a new and great experience. So yeah.
Oh my God. You were incredible. That was so much good information, from the tips to the cases, everything. Yes, everything. I know I'm personally definitely going to go back and rewatch that video and look over some of that stuff you said, because a lot of good information.
Oh, glad to hear that.
So cool. We really appreciate it. We can tell you were thinking about this, and you're in clinic and oh, hey, that's a bad cut. Let me take a picture of that real quick. I have this thing coming up. So really appreciate you doing that. Thank you so much.
Yeah, thank you. So, hey, I'm more than happy to come back for another session. If I see another cool case or like an abscess, I know a lot of people mention Dr. Pimple Popper. So if I see an abscess, I'll definitely ask the patient and take pictures and record and show you guys next time.
Cool. That's
Absolutely. We'd love to
awesome.
have you, yeah.
So you guys heard it first here. We might be having another guest appearance. Thank you so much for that. It seems like everybody really loves you. The support in the chat is awesome.
Oh, yes. Thank you so much for everyone. To everyone. Everyone's saying thank you and heartwarming.
Yeah, absolutely. You deserve it.
Supportive.
Yeah, and definitely please take the time to follow her Instagram. That's right there. We've been following it ourselves, and there's a lot of good info on there, a lot of cool little neat things to check out. So highly recommend for you guys.
Okay. Thank you guys. Have a good night.
All right. Have a great night.
Thank you.
Okay, guys. So we'll be posting that quiz right here in the YouTube chat, as well as on our Instagram here in just a second. Here's something about some more on that.
So the quiz, once again, it'll be 5 questions, all multiple choice, very straightforward. As long as you get 4 out of 5 correct, you will get a certificate. And this certificate will count for 2 hours. And then you'll have 1 hour to complete that.
Awesome. And yeah, like we said earlier, we're going to be having a lot of presentations in November. So stay tuned on our Instagram, on our YouTube. We'll try and get that information out to you guys as quickly as possible. We do have one coming up on the 10th and a lot more dates to come. So yeah, stay tuned, guys. Thank you so much. We really appreciate you being here. Thank you so much.
Yes, everybody's so supportive and so kind. We really, really appreciate that.
Definitely. Y'all are awesome. So yeah, we're gonna go ahead and stop it here. We'll be in the chat if you have any questions about like the technical details, quizzes, or anything. Just let us know. We'll be hanging out. All right. All right. Good night. Thank you so much.
Thank you.